Welcome everyone to the third International Health Science Conference Surgery session. My name is Karolina Stashkevičiūtė and I will be leading this session today. First of all, on behalf of Student Scientific Society of Lithuanian University of Health Sciences, I would like to thank our sponsors, Francenius Kabi, Ambos, Medaxa, OrgMed, Mediateka, Optometrijos Centras, Aromama, and others for helping to organize this conference. We believe that it provides an opportunity to all participants to share their interests and achievements in various biomedicine fields. We hope that this conference will help build friendly and professional relationships and share experience in fundamental medicine, biomedicine, dentistry, pharmacy, and public health with young scientists all over the world. Also, I would like to express gratitude for all of you in today's jury. Professor Dr. Mindaugas Jevaltas, Professor Dr. Mindaugas Kiudelis, Professor Dr. Žilvinas Saladžinskas, Dr. Saulius Švagždys, and Dr. Saulius Grižas. Before starting the session, I would like to remind you some rules. Today we will hear 8 presentations. All of the presentations will be evaluated by the jury. Based on the average scores given by the jury, we will choose one winner from the section. The winner will get amazing sponsored awards. €50 coupon for medical clothing, €25 bookstore coupon, AMVA subscription, glasses for computer work, and other marvelous prizes. We will contact you within 2 weeks from the conference. Moreover, presentation should last no more than 7 minutes, and after that, 2 minutes will be dedicated for juries and listeners' questions and remarks. If your presentation will take more than 7 minutes, you will be asked to go to the final slide and finish your presentation. I ask the jury to fit in time as well. In addition, you will receive your certificates for presenting your abstracts in your emails after the conference. Now I would like to ask if anyone have any questions before starting. If there are no questions, then I think we can start, and best of luck to all the presenting authors. And I would like to invite the first presenter to give us first presentation, urethroplasty buccal mucosal graft in urethral stricture treatment, a literature review.
Hello, my name is Gustas Sasnauskas, and I will present the topic, urethroplasty using buccal mucosal graft in urethral stricture treatment, literature review. It was prepared by me and Aivaras Grybas. Urethral strictures are most commonly caused iatrogenically by damaging the ureter, internally during endoscopic procedures, externally during abdominal or pelvic operations, or by radiotherapy. Here you can see how a stricture appears on a retrograde piellogram. It is marked red. Short strictures can be treated by endoscopic dilatation, incision and dilatation, or excision of the stricture and ureter repair. However, long recurrent proximal urethral strictures are difficult to treat. There are various surgical procedures for proximal urethral reconstruction, such as ileal ureter replacement and even renal autotransplantation. However, most of them are very traumatic with frequent complications and are often ineffective. An alternative to these procedures is buccal mucosal graft urethroplasty. Buccal mucosal graft is commonly used for urethral reconstruction. It is recognized as the gold standard approach for complicated urethral strictures. Similarly, buccal mucosal graft has been tested for reconstruction of long proximal urethral strictures, and it achieved promising results. These are the main stages of the operation. First, the urethral stricture is prepared Then the BMG is harvested from the inner cheek and prepared on a side table. The intraoral defect is closed. Anastomosis of the ureter is performed inserting a double J stent before closing the anastomosis. And finally, an omentum flap is mobilized and wrapped around the anastomosis. This image depicts an onlay technique of the anastomosis. It can be also performed in a tubular way or by other modified technique. Our aim was to evaluate the results of publications on ureteroplasty using buccal mucosa graft in urethral stricture treatment. Retrospective studies and clinical case reports from the 1999-2020 period investigating the effectiveness of BMG ureteroplasty were found in major databases. In the studies, we evaluated urethral stricture length, type of the operation, operating time, follow-up time, post-operative complications, and the effectiveness of the treatment. The effectiveness of the treatment was assessed by clinical and radiological examinations. 7 existing publications were found and analyzed. This included the first ever published report on buccal mucosa graft ureteroplasty by Nod et al. As you can see, there were not many cases of these operations. Overall, 52 patients were included in the studies. There were 5 open ureteroplasty studies with overall 21 patients. You can see the generalized results in the table. I want to emphasize that these studies achieved close to 100% effectiveness with a quite low complication rate, and the complications were difficulty to whistle due to buccal mucosa graft harvesting, urinary tract infection, fever of unknown cause, or ileus. There were no major complications or deaths. 2 robot-assisted ureteroplasty studies with overall 31 patients achieved similar results. Complications were camera port hernia, compartment syndrome, or were related to comorbidities and anesthesia. In the Lee et al. Study, 10 out of 12 patients were stricture-free after the operation. The stricture has recurred for 2 patients. However, after endoscopic balloon dilatation, they also remained stricture-free. A similar case was recorded in Zhao et al. Study, where 18 out of 19 patients treated successfully with BMG ureteroplasty, and the 1 remaining patient was additionally treated with balloon dilatation and also lived stricture-free. So practically speaking, these interventions paired with some endoscopic procedures achieved 100% effectiveness with a low complication rate and no death. Of course, due to the rarity of long proximal urethral strictures, there are only several studies on BMG ureteroplasty, and they all have some limitations, such as small sample size, heterogeneity of the stricture etiology and length, and diverse reconstruction techniques. However, the available results are promising, with treatment effectiveness varying from 83% to 100% and a low complication rate. BMG ureteroplasty for long proximal urethral strictures could be considered as a more safe and effective alternative to the usual urethral reconstruction methods. Thank you for your attention. Maybe you have any questions. These are my references.
Thank you, Gustas, for your presentation. Now I would like to ask if anyone or jury has any questions or comments.
Professor Yevaldas, I have the question.
Yes, please.
Do you think that this ureteroplasty is suitable for any reason of strictures? I mean that, let's say, do you think that it is the same to do surgery for the patient with tuberculosis or the subject after iatrogenic lesion of ureter? Do you think the reason might influence the results or not? What is your opinion?
Well, my personal opinion is that patients should be chosen based on their situation, and your mentioned example of tuberculosis, I think it would mostly be suitable for this type of reconstruction because of the infiltrations and well, the changed the anatomy of the ureter. And well, I don't have the experience, of course, but in my opinion, it is not suitable for every type of urethral stricture.
Thank you.
Do we have any more questions? If not, then thank you, Gustas, again for our presentation.
Thank you.
Jerry, for the question. And now I would like to invite the presenter to give us second presentation, long-term outcomes of anastomotic leakage after colon cancer resection, a systematic review.
Hello, dear colleagues. I somehow could not upload my presentation. So maybe you could do that for me.
Can you now upload your presentation?
When I click actions, I can only take presenter, but I could not can upload my presentation somehow.
Now I can see we have your presentation.
Yeah, okay, thank you. So my name is Artemis Shirbis. I am a medical student in the Faculty of Medicine of Vilnius University, and today I will present a topic on long-term outcomes of anastomotic leakage after colon cancer resection, a systematic review. And as you can see in those pie charts, the topic's role is undeniable because colorectal cancer hits the top 3 among all cancers by incidence and even the second place by mortality rate. And according to the literature, anastomotic leakage is considered as one of the most severe complications in colorectal surgery. And depending on publication, incidence of this complication varies from 2 to 19% of all colorectal surgeries. So the main aim of this study was to analyze the impact of anastomotic leak on long-term outcomes after colon cancer surgery. And into methods. Literature search was performed in 5 main databases, including Cochrane Library, Embase, Web of Science, Central, and the PubMed. Publications were searched between January 2000 and October 2020, and preferred reporting items for systematic reviews and meta-analysis guidelines were followed while performing this review. And main inclusion criteria were original studies and studies analyzing anastomotic leakage impact on overall survival and recurrence. Only patients with colon resection for cancer should be included, and minimum 5-year follow-up period. Study assessment was performed using the quality assessment tool for systematic reviews by Moore et al., which consists of 6 main areas that include study participation, or just simply saying sample size of publications, then study attrition, the number of patients that reached the end of follow-up period, then prognostic factor assessment, possible variable evaluation, which could have an impact on obtained results, then outcomes assessment and data analysis as well. And for long-term oncological outcomes assessment after anastomotic leakage, two groups were formed: patients with anastomotic leakage and without anastomotic leakage, and statistical analysis was performed with WinPepi statistical tool for systematic reviews and meta-analyses. So moving to results, and after initial search, nearly 5,000 potentially relevant studies were found, although all inclusion criteria met only 10 studies. And median quality assessment tool result was 13 out of 16 points. So in average, all included studies had a quite high quality actually. And talking about anastomotic leak and short-term mortality rate, and analyzing all the reviewers' studies, average rate of anastomotic leak with a total sample size of nearly 55,000 patients was 3.7%. And anastomotic leakage group had a higher short-term mortality rate compared to group which did not experience the anastomotic leakage. Although, as you can see, only 4 studies reported on short-term mortality rate results. Talking about overall survival, in the end of a 5-year follow-up period in non-anastomotic leak group, average overall survival among the 7 studies was 73%, and in an anastomotic leak group, 58%. And the difference between the groups was statistically significant, actually. And talking about disease-free survival, quite comparable results were obtained there, and the difference between the groups was statistically significant as well, although only 4 studies reported on disease-free survival in the end of follow-up period. Moving to cancer-specific survival, and as well in the end of 5-year follow-up period in non-anastomotic leak group, average cancer-specific survival was 87%, and in anastomotic leak group 69%, and the difference between the groups was statistically significant as well. And moving to recurrences, actually, there was no sufficient data for distant recurrence analysis because only few studies reported on results like this, although 5 studies reported on local recurrence rate in the end of follow-up period. And it appears that in non-anastomotic leak group, by the end of follow-up period, there was 6% of local recurrence rate in average, and in anastomotic leak group 7.5%. And the difference between the groups was actually statistically insignificant, which was quite actually surprising. So in conclusion, based on our review results, anastomotic leakage may be a prognostic factor of worse and long-term oncologic outcome in patients undergoing colonic resection because anastomotic leakage has a significant negative impact on overall disease-free and cancer-specific survival, and therefore close follow-up must be included into observation after surgery in order to prevent the terrible aftermath of this complication. This is my main references, and thank you for your attention, and now I would be happy to answer your questions.
Thank you, Thomas, for your presentation. Yes, and I would like to ask jury if they have any questions or comments.
Good day, Mindaugas Kudris. Can I answer one question? Can I ask one question?
Yes, please.
Mindaugas Kudris from Clinical Surgery. Thank you for your presentation. And my question is, how can you explain why is so difference between anastomotic leakage group and without leakage group? Why the results is worse in this anastomotic leakage group? How can you explain? 5-year survival rate and local recurrences are much worse in this anastomotic leakage group.
Thank you for your question. And actually, talking about survival, the worse overall survival in anastomotic leak group was probably correlated to the infectious complications after the complication occurred. Maybe because of peritonitis and conditions like this, but actually we did not obtain the significant difference in local record. So,
And one more question, short one. Are there differences between early mortality rate between these two groups? Or hospital mortality rates between these two groups? Maybe more patients died in the group where this anastomosis leakage appeared. And why? Because of this, there are or not. So, is there a differences in mortality rate between these two groups?
yeah, there was difference in 30-day mortality rate of the procedure. It was higher in anastomotically group, and my explanation would be just again due to infectious complications after the procedure.
May I have some comments? Thank you for your presentation. It's very nice because this is a quite huge problem in colorectal surgery. But from my point of view, it is necessary to divide the surgery of large bowel in few groups because, as you know, the anastomotic leakage is more common when you're doing rectal resection compared with sigmoid resection or hemicolectomy. So this was my one comment. And second, I think maybe for your future plans of your work, it is necessary also to compare stages of the large bowel and according to the surgery, because we have also comorbidity patient, and I think it also depends on this high complication rate. Just my comments for your future. Thank you for your presentation.
Thank you very much.
Do you have any more questions? If not, then I would like to ask Thomas to turn off his camera. Thank you again for your presentation. Thank you, jury, for your questions and comments. And I would like to ask our next presenter to present us transcutaneous electric nerve stimulation reduces acute postoperative pain and not affect the early quality of life following inguinal hernia repair.
Hello. I have the same problem as the last presenter. I cannot open my presentation, so I'll need some with uploading it.
Okay, we'll try to help with this.
Thank you very much. So hello again. I am 5th year med student Jovidas Vitakunas, and I'm going to present transcutaneous electric nerve stimulation effect on acute post-operative pain after open inguinal hernia repair. This trial was accomplished with Audrius Paršeliūnas MD and Saulius Paškauskas doctor's degree. In modern hernia surgery after introduction of mesh, recurrence rates reached constant and low levels, though all the attention has been paid to post-operative pain and early quality of life, not early, just quality of life. The most common complaint following inguinal hernia repair is acute post-operative pain. American Society of Anesthesiologists recommends acute post-operative pain to be treated multimodally. Multimodal treatment is a combination of analgesics and non-pharmacological interventions. Transcutaneous electric nerve stimulation, or TENS, is a safe, non-pharmacological method to control post-operative pain. TENS is also modern, easy to use, have easy access, and is affordable, just like a remote control. TENS effect on acute post-operative pain was shown in previous trials in various surgeries, such as thoracotomies, major and minor visceral surgery, gynecological and neurological surgery. TENS effect on after inguinal hernia repair was found also controversial. The aim of our trial was to evaluate the role of TENS in a multimodal treatment of the post-operative pain and early quality of life following open inguinal hernia repair. Our objects were to assess TENS effect on pain relief in rest, when walking, and when standing up. Also to assess TENS effect on analgesic consumption, and to assess TENS effect on early quality of life. 80 male patients with unilateral inguinal hernia treated by elective surgery were recruited to a prospective randomized double-blind placebo-controlled clinical trial at Kaunas Hospital from August 2018 to November 2019. Patients who had primary hernia had no TENS in the past, American Society of Anesthesiologists status 1 to 3, had no cognitive, language, or other disorders, were included in the trial. On the first post-operative day, participants were randomly allocated into two random groups, TENS group and placebo TENS group. Computer-generated sequence was used for randomization. At first, TENS group were assigned to a local and segmental conventional TENS with self-adhesive electrodes. Procedures were done on the first and second post-operative day, twice a day for 30 minutes. Every participant received 4 procedures in total, but just in placebo TENS group, the procedure was imitated. All of them had the same experience, but the stimulation intensity was set to zero. To zero. The picture represents how the electrodes were placed during the procedure. Both groups received analgesics according to a prearranged plan. Our primary outcomes were measured using visual analog scale, or VAS, in rest, when walking, and when standing up. Secondary outcomes were total analgesic consumption and early quality of life, which was measured using hernia-specific Caroline's Comfort Scale on second post-operative day. Here you can see the flow of the trial. Eligible patients were randomized and allocated into 2 random groups. Later on, they were analyzed. And now on to the results. There were no difference in the mean VAS pain score before all procedures in both groups. But the mean VAS pain score in TENS group in comparison with placebo TENS group was significantly lower after each procedure. This effect was seen during all activities. Total analgesic consumption during the first 2 post-operative days were significantly higher in the placebo TENS group compared with the TENS group. And also the tendency that TENS improves hernia-specific quality of life was apparent in sensation, in movement and pain domains, as well as in total score. But no significant difference was found between the TENS group and the placebo TENS group. I believe that further data is needed to prove this difference, but there is a doubt that this difference will be clinically important. In conclusion, TENS effectively reduce acute post-operative pain in different activities. TENS reduced pain medication intake on the first 2 post-operative days. However, it has no effect on hernia-specific quality of life. Thank you for your attention, and I would gladly answer your questions.
Thank you, Jorvidas, for your presentation. And maybe jury has any questions or comments.
Thank you. Mindaugas Kudilis. Can I ask one question?
Of course.
Thank you for a nice presentation. My comment and question is, of course, the pain after inguinal hernia surgery depends not only, but the surgery is also one of the main problems that causes postoperative pain. So my question is, what type of surgery was performed to the patients? If it was the mesh, plastic with the mesh or without the mesh, what kind of mesh was used? Was the same mesh was used in all surgeries, or the mesh was fixed with the sutures or without the sutures? This all reasons also affects the pain postoperatively.
Yes, so to answer your question, there were a variability between the patients. You can check the more detailed research on the exact scientific page on our work, on our trial. But I believe so that there's a difference between patients who had like mesh and who hadn't. I don't exactly remember if all the patients had the exact same operation, but there was the one thing that was same for all the patients, that it was open inguinal hernia repair.
One more comment. When you present the study, randomized study, you are not analyzing postoperative pain, you have to show 1 or 2 slides according your patient groups. And of course, once you have to mention the surgery and to compare these groups according from the surgery point. So this is for your future presentation and your future scientific work. Thank you.
Okay, thank you for your comment. Are there any more questions?
Geraldas, you're with us. Congratulations. Nice work, nice study. But please help me. What was your personal contribution in this all quite difficult study? Can you describe us?
Yes, so I had like a scientific supervisor, which was Audrius Paršeliūnas, and I participated in almost all activities during the trial. I helped to evaluate visual analog scale for the patients. I helped to give out the questionnaires to fill for the patients. Also, I had the opportunity to be a part of writing a trial or in contributing my having a contribution in the writing of the work, and also I participated in the analyzing the statistics.
Okay, thank you. Thank you.
Can I ask you a question?
Of course. I cannot.
Stimulation can influence the pain and other things in the longer period of acting. Why do you prefer only 2 days after the operation to only after 2 days involve your patient in this trial, not for example, for a week or maybe a bit longer?
Usually, patients don't need any more than 2 days post-operative to handle the pain. Also, tense effect is as much the more you use the tense, it gets less effective to time because people get used to it. And also the questionnaires. Excuse me, what?
Do you have any data about it, the period of tense? In the 5 days or 7 days or 10 days?
I don't, but I believe there are trials that check this point of view. Also, we just we chose those points of view, like the first post-operative day, second post-operative day, and then the longer term. So these were the most important days for early quality of life.
Do we have any more questions? If there are no questions, I would like to ask Javdas to turn off his camera.
Thank you.
Thank you again, Javdas, for your presentation, and jury for questions and comments. Now I would like to invite next presenter, my colleague, to talk about analysis of native septic hip and knee arthritis.
Hello everyone, do you see me and do you hear me well? And
Yes.
do you see my presentation?
Yes,
so, very well. So, to begin, my name is Evaldas Šivickas, and today I'll present my colleagues Karolina Staškevičiūtė and Dr. Justinas Tučinskas study called Analysis of Native Septic Hip and Knee Arthritis. And we chose specifically this disease because it's not common, but very serious problem in orthopedic traumatology department. And it's associated with severe complications, chronic morbidity, and high mortality rate. The aim of our study was to identify native septic arthritis etiology, pathogenesis, and outcomes. And we studied 32 patients from Kaunas Clinics, Department of Orthopedics and Traumatology, from 2018 to 2020. And we included patients with only native septic hip and knee arthritis. And we investigated microbiological, laboratory, radiological findings, treatment methods, and outcomes. In this diagram, you can see that we had more hip and knee native septic arthritis, and we had in our population there were more males than females, and that our mean patient age was about 60 years. So that means that we had more elderly people in our population. And half of our patients had arthrosynthesis done. And below you can see mean white blood cell count and polymorph nucleic cell. These numbers are from synovial fluid. And on the right side, you can see mean preoperative CRP and white blood cell count from peripheral blood. And these numbers are not only from the patients with arthrosynthesis, but from all of our population. In this diagram, you can see pathogenesis of native septic arthritis. We had in our patients, 2 patients were infected by direct inoculation, 8 by percontinentatem, or in other words, by adjacent tissues, and the rest by hematogenous spread of pathogen. So, average duration from symptoms to surgical treatment were 50 days. For some of you, this number may seem a bit off, but it is because some of the patients were treated in other hospitals before, or they were treated for other diseases. And it is worth noting that less than half of the patients received antibiotic therapy before hospitalization. As I said before, it's because we were treated for other diseases or we were treated empirically before hospitalizing in Kaunas Clinics. And in this diagram, you can see surgical treatment methods. I can see that all of our patients had surgical treatment done, and 1 patient had exarticulation. There were 3 arthroscopies, and the rest were 2-stage surgical technique, 10 with spacer, 10 without spacer, and 18 with cemented spacer. Then we investigated microbial growth from synovial fluid or synovial membrane tissue taken during surgery. So about 1/3 samples were negative, and 4 out of 9 cases, patients received antibiotic therapy before hospitalization. So it may intervene with sample results. 2 cases were polymicrobial and the rest monomicrobial. In this diagram, you can see that the most common causative pathogen was Staphylococcus aureus, and in descending order, gram-negative anaerobes, Streptococcus and Enterococcus species, and Staphylococcus epidermidis. And we found that the most common used empiric antibiotic therapy was unazin monotherapy or unazin plus vancomycin combination, and average duration between 2 surgical stages was 65 days. And mortality rate, we found that 4 patients died within 6 months from their diagnosis. And to conclude, I can say that the most common pathogen of hip and knee native septic arthritis was caused from hematogenous spread of Staphylococcus aureus. Majority patients were treated with 2-stage surgical technique and antibiotic therapy. And after intervention, there were repeated surgeries done due to infection. And nevertheless, a high mortality rate was observed within 6 months from the diagnosis. So, do you have any questions?
Thank you, Evaldis, for your presentation. And now I would like to ask the jury if they have any questions. If we don't have any questions, then I would like to ask Evaldis to turn off his camera.
Thank you.
So thank you again for your presentation. I would like to remind for our jury to not forget to evaluate all presentations that we have today. And then I would like to ask our next presenter to present us minimally invasive versus open primary linea alba and midline incision hernia treatment, early follow-up results.
Hello, my name is Matas Pažusis. I will present early follow-up results of minimally invasive primary linea alba and midline incisional hernia treatment. Primary and incisional hernia are the most common disease in general surgery. However, despite the high price of mesh for laparoscopic surgery, most surgeons choose open mesh repair. In recent years, I used new minimally invasive hernia repair techniques for small and medium size, such as retromuscular or subcutaneous approach. Minimally invasive hernia repair showed better outcomes compared with open mesh repair. Aim was to compare the early follow-up results of minimally invasive and open sublay mesh repair for small and medium-sized primary linea alba and midline incisional ventral hernias. It was prospective cohort study of patients who underwent for small and medium size of primary and incisional ventral hernia mesh repair. The patients were divided into 2 groups, minimally invasive and open repair. Post-operative pain was assessed by using WAS scale. All patients were invited for follow-up in our institution after 1, 3, and 6 months. A physical examination and ultrasound were performed to evaluate for complications such as seroma, mesh dislocation, hernia recurrence. A minimally invasive group consisted of laparoscopic transabdominal intramuscular technique. It's made by closure of peritoneum posterior rectus sheath incision, midline and hernia defect closure, transversus abdominis release, and mesh deployment into the retromuscular space. And the subcutaneous only laparoscopic approach, SCOLA technique, making subcutaneous dissection, anterior application using running Babbitt suture, mesh placement and fixation using interrupted sutures. And the open mesh repair group, Sublay technique. The study included 40 male and 20 female. The mean patient's age was 56 years. There were 21 patients in the minimally invasive group and 30 were in open mesh repair group. Primary and medium-sized hernia were more common. The operating time was significantly longer for the minimally invasive surgery group compared with open Sublay group. There was significant lower post-operative pain in minimally invasive group compared with open repair group at the first 72 hours after operation. Analgesic use was lower in the minimally invasive group. Hospital stay was longer in the open mesh group compared with the minimally invasive group. And wound seroma was found for 7 patients in the open mesh group and 7 in the minimally invasive group. 1 patient had hernia recurrent after open mesh repair surgery, and mesh dislocation was found for 2 patients after minimally invasive hernia repair. And for conclusions, minimally invasive hernia mesh repair operating time is longer compared with open mesh repair technique. Minimally invasive techniques are associated with significant lower postoperative pain at first 3 days after operation. After minimally invasive hernia mesh repair, hospital stay is shorter. The use of analgesic was more common in open mesh repair group, and the rate of postoperative wound seroma was less in minimally invasive group. Thank you for your attention.
Thank you, Matas, for your presentation. Now I would like to ask jury if they have any questions or comments.
So for this, if it's possible to ask. Can I ask a question?
Yes, of course.
Okay, thank you very much for a nice presentation. I would like to ask one question in general. What is your opinion about these types of operation? Which is the better? How do you think?
In my opinion, minimal invasive hernia repair is quite new techniques, and the surgeon would have more experience for these techniques, and for patients, minimal invasive SCOLA or TARM techniques are better compared with open, because the post-operative pain is lower, the analgesic use is much more lower, and the hospital stay is shorter. So minimally invasive techniques such as SCOLA or TARM, I think it would be the future most popular techniques.
Thank you very much.
I have a question, Solzhenitsyn. Did you analyze the long-term results according to literature of this technique, minimal invasive technique? What about the long-term results and the literature review of this method?
As I said, these techniques are new, and no literature of long-term results. Only in the literature we can find the early follow-up or only in hospital stay results. But these results, what we done was the first with analyzed the early follow-up results.
And the last point, do you have idea to continue your studies looking at the long-term results of this perfect method of operation?
Yes, I have idea that these techniques can be continued for operation and data collected to see the 1 year, 3 or 5, 6 year longer time results.
Thank you.
Do we have any more questions? If not, then I would like to ask Matas to turn off his camera. Thank you again, Matas, for your presentation and jury for their questions and comments. And now I would like to ask our next presenter to present us the trans-contractor treatment evaluation, effectiveness of limited partial fasciitis.
Hello, it is a pleasure to be here and present you our work, which is called Dependence Contracture Treatment Evaluation, Limited Partial Fascectomy. It is prepared by me, Mantas Flamkinas, Lithuanian University of Health Sciences medical student, and two co-authors, medical student Rokas Paškevičius and plastic and reconstructive surgeon Gediminas Samulėnas. First of all, dependent contracture is a progressing hand disorder of polygenetic and multifactorial origin. It presents as thickening of a palmar aponeurosis and results in the development of nodules, longitudinal bands, and formation of finger contracture. The prevalence of dependence contracture ranges widely, from 2 to 42%. Treatment of dependence contracture is aimed at excision of affected palmar aponeurosis, and extension deficit is established as a method to measure treatment effectiveness. And limited partial fascectomy is a widely accepted traditional surgical approach, even though recent decades has increased interest in minimally invasive methods. There's still lack of studies evaluating these methods, and limited partial fascectomy has to be evaluated in modern surgery setting. And of course, our aim was to evaluate limited partial fascectomy effectiveness in treatment of dependence contracture by comparing preoperative and postoperative extension deficit and the effect of digits and disability of the upper limb. And a prospective study was performed, including patients admitted to the Department of Plastic and Reconstructive Surgery in Hospital Lithuanian University of Health Sciences, Kaunas Clinics, for limited partial fascectomy in 2017-2019. Approvals for this research were issued by Lithuanian University of Health Sciences Bioethics Center, a Kaunas Regional Biomedical Research Ethics Committee. Informed consent has been obtained from all individuals in this study. And diagnosis of dependent contracture was based on physical examination. Extension deficit was measured by gonometry, and staging was done according to Tobiano classification. Patients with multiple digit contractures were counted as a single case, taking the finger with the most expressed contracture as a reference. Furthermore, disabilities of the arm, shoulder, and hand questionnaire was performed. Follow-up examination were carried out after 6 and 12 months. And that was analyzed using IBM statistical package for social sciences, and repeated measures and ANOVA with post-hoc tests were used to compare means normal distributed data. And between 2017 and 2018, there was 111 patients. In our study, 94 of those were male and 17 females. Mean age was 59 years old. And then Tobiano staging classification was used. It is a grading system based upon the total flexion deformity of the fingers. It has 4 stages from 1 to 4, and 2 stages, stage N, which means nodules, and stage 0, which means totally normal hand. In our study, most patients presented with a second stage of dependence contracture. In this study, we evaluated metacarpophalangeal and proximal interphalangeal joints extension deficit. Average digits extension deficit preoperatively was 69 degrees in males and 63 degrees in females. And after 6 and 12 months follow-up, extension deficit in males was 4 and 7 degrees and 6 and 8 degrees in females. And extension deficit was significantly lower in 6 and 12 months after limited partial fascectomy. Furthermore, Disabilities of the arm and shoulders and hand, this questionnaire was evaluated. It is designed to assess the functional disorders of the musculoskeletal system on the upper extremity, daily life activities. The questionnaire consists of 30 main and 8 additional questions about daily life, their work, and hobbies. Each question is scored from 1 to 5 points, and then scores calculated using special formula. Maximum score may be 100 points, and it reflects upper limb dysfunction accordingly. In our study, mean pre-operative DASH score in males was 14 and 27 in females. And after 6 and 12 months follow-up, DASH score was 5 points in males and 4 points in females. And DASH results were significantly lower at 6 and 12 months after limited partial vasectomy. And as we saw in our results, extension deficit and disability of affected fingers and hand was significantly lower after limited partial vasectomy. Therefore, limited partial vasectomy has been evaluated to remain an effective method to eliminate dupuytren's contracture, providing good functional results at 1 year's follow-up. And these are references that have been used in our introduction. And thank you for your attention. Maybe there's any questions about our study.
Thank you, Mantas, for your presentation, and I would like to ask our jury if they have any questions.
Mindaugas Kuderis, thank you very much for a nice presentation. And I have few questions. One question, can you say the differences between limited fasciotomy technique you mentioned here and extended fasciotomy? What are the differences in the surgical technique?
Yes, of course.
And the second one, what was your personal input or contribution to this study? Thank you.
Okay, of course. First of all, about full and partial vasectomy. Partial vasectomy is basically golden standard in plastic surgery. And for last maybe 20 years or something like that, full vasectomy is basically never done in world because it is very invasive and it results it's not very great. There's lack of skin, there's no way to close the wounds and so on. So basically the results is not great. So basically no centers do this. And basically partial vasectomy is done only on the spot where those affected fingers are. Incisions done on those affected dupuytren's contractures. And full vasectomy would be done on the wall, on the whole palm, and wall aponeurosis would be removed. That's very invasive and not very useful for the patient. And for the second part, this study was much bigger. There's some genetic tests and so on, but in this thesis, we present only part of our study. And me and my colleague Rokas, we done planning of the study, we done follow-ups to contact the patients for them to arrive. We done questionnaires, put those questionnaires to computer systems and do some little counting. Most counting was done by our Dr. Gediminas Samulėnas, and diagnosis was performed by him too. And all surgeries were performed by all doctors of the department.
I have one question, Solodzinskis. You just analyzed 1 year follow-up after this surgery. Do you have some results from maybe other centers about longer-term results, because this disease is quite invalidizating them? So maybe you have some comments to my question.
Yes, we have seen some results from other centers. This technique for partial vasectomy is the most common, and the results are the best from all treatment methods, no matter it's minimal invasive or very invasive. Basically, extension deficit, the finger is less contracture from this procedure is the better result. And after recurrence of this disease, because it's based on genetics, it's many patients after a year or two, this disease appears again. But after fascial fascectomy, results are better, and only less than 10 to 20% of people have this recurrence. After minimal invasive procedures, this result is much bigger, like twice bigger.
Thank you.
You're welcome.
So, Socrates, thank you very much for your great presentation. I would like to ask one question. Maybe it is extended of the Mindaugas Kidelis question. There are partial or all fasciectomy, but maybe there are another treatment methods which can be applied. I mean, could you mention them?
Mhm. Yes, of course. There's basically, if I'm right, 5 types of fasciectomies, from very small to very big ones. And there's fasciotomies, that only the string is cut, but nothing is excised. And there's some minimal invasive methods, like needle aponeurotomy, then used many times to puncture with needle that nodules of those strings to cut the adipotens contracture. And there's some injections of Clostridium histolyticum enzymes, which basically dissolves those collagen contractures, but those results of minimal invasive treatments are not very great, and those enzymes are really expensive and not possible in Lithuania to get because of the price.
Thank you very much.
Do we have any more questions?
Thank you.
Okay, then I would like to ask Mantas to turn off his camera. Thank you, Mantas, again for your presentation. Thank you, jury, for questions and comments. Also, I would like to remind one more time for jury to evaluate presentations because we still don't have evaluation from all the jury members. And then I would like to ask next presenter to present us evaluation of chronic leg wounds healing rate. Do we have our next presenter with us? I'm sorry, Kasparas, you are muted.
Good morning, everyone. I will give you a presentation about evaluation of chronic leg wounds healing rate made by me, student Kasparas Budreckis, and the supervisor of this research is Dr. Domantas Rainis. First of all, wounds are characterized as a disruption of normal skin architecture and function. A wound becomes chronic when it fails to proceed through normal phases of healing, which are inflammation, proliferation, and maturation. These stages can be seen in the scheme on the right side. Even though modern medicine is capable of marvelous things, chronic wounds healing remains a severe and very expensive burden for both patients and physicians. Therefore, in this research, a few mathematical formulas have been used to predict wound closure time by measuring wound healing rate. The main aim of this research was to determine a probable healing time of chronic leg wounds based on known changes in wound size during treatment. What is more, from the data of 2014 to 2018, a retrospective study has been made in Lithuanian University of Health Sciences Hospital Kaunas Clinics, Department of Plastic and Reconstructive Surgery, in which we reviewed 48 patients and 60 chronic leg wounds overall. According to treatment protocol, the follow-up was carried out until a complete wound closure, but for a maximum of 8 weeks. On average, it was 49 days for each patient. Analysis was made of the first and the last measurement of the wound, and by using already contrived mathematical formulas, we calculated the area, perimeter, healing rate, and prognostication, preliminary time in days for a wound to heal. And lastly, all features were statistically evaluated by applying descriptive statistics. In general, there were 48 patients and 60 chronic leg wounds, of which 15 were fully closed during hospitalization time, and the remaining 45 wounds have diminished significantly. Added to this, primary and ultimate average values of wound perimeter were 5.85 centimeters and 3.36 centimeters, with the change of 2.49 centimeters. Additionally, primary and ultimate values of wounds area were 3.37 square centimeters and 1.73 square centimeters respectively, with the change of 1.64 square centimeters. Furthermore, the quickest healing wound had a speed of 0.47 millimeters per day, and the slowest wound convalesced at 0.002 millimeters per day. And the average adjusted mean healing rate of all wounds is 0.087 millimeters per day, with the standard error of 0.011 millimeters per day. Finally, we calculated a prognosis for wounds that have not been fully healed, which is 147 days. Unfortunately, we could assess a prognosis for only 45 lesions. We were unable to quantify a prediction for 15 patients, as they simply had their wounds fully healed in the course of treatment. Conclusions that we came up: an average follow-up time of 49 days, a provided treatment reduced mean wound perimeter by 42.6% and wound area by 48.6%. Adjusted mean healing rate of wounds is 0.087 millimeters per day, and with this mean healing rate, the estimated wound closure time is approximately 147 days. And some practical recommendations. A final prognosis of wound healing time, which is 147 days, shows the enormity of this problem and demonstrates how long it takes for a chronic wound to heal. Apparently, it is really not possible for patients to stay in the unit for this amount of time. So in this case, reinforcement of dispensary care is inevitable. More compensated medications should be introduced, or maybe physicians could perform regular visitations and wound measurements for patients at home. Furthermore, by analyzing wounds data regularly, a physician could easily customize treatment strategy and give more aggressive and more specific treatment. For example, if a wound does not show positive dynamics in first 2 or 3 weeks, some alternatives then should be invented, or even other reasons that have caused a wound should be thought of. In addition, wound measurements could be a self-examination for a physician, as well as it would be really convenient for patients. They could monitor their healing process and could start looking for another wound healing specialist if wanted. That would be it. Thank you very much.
Thank you, Kasparas, for your presentation, and I would like to ask jury if they have any questions or comments.
Mindaugas Kudelis, thank you very much for your interesting presentation. I have few questions. One question, was the treatment options the same for the wounds, or you had several separate treatment options? And the second thing is the localization of the wounds. Was the localization the same, or was it different localizations? And if it was different, do you notice the correlation between the localization and the healing time?
Thank you for your question. So all patients received equal treatment, which contained of using sterile bandages and trying to keep wounds moist. And in addition, every patient obtained compressive therapy. And answering your second question, so we didn't locate the differences between locations of the wounds, but all wounds were located in the back side of the tibia. So that would be an answer. But we didn't find any correlations, and we didn't test it.
Thank you.
So, with this, I would like to ask you one question. Thank you very much for nice presentation. And my question is about the prognostication criteria. I didn't hear any criteria according to which you can prognose your wound healing rate or wound healing speed, maybe. Thank you.
So as I mentioned, we were unable to quantify a prediction for patients who had their wounds fully healed in the course of treatment, and for those who had negative dynamics in the course of treatment.
Do we have any more questions? If not, then I would like to ask Kasparas to turn on his camera.
Thank you.
Thank you again, Kasparas, for your presentation. Thank you, jury, for your questions. And now I would like to ask us to go to final presentation, significance of persistent prostate-specific antigen on long-term oncological outcomes in men with low-risk prostate cancer who underwent radical prostatectomy.
Hello. Again, my name is Gustas Sasnauskas, and I will present the topic Significance of Persistent Prostate-Specific Antigen on Long-Term Oncological Outcomes in Men with Low-Risk Prostate Cancer Who Underwent Radical Prostatectomy. Prostate cancer is often treated with radical prostatectomy because it provides good long-term oncological outcomes. The disease can be divided into risk categories by preoperative and postoperative characteristics. Based on literature, about 83% of low-risk group patients survive 10 years. After the surgery, all patients are monitored by evaluating serum prostate-specific antigen. The term persistent PSA is defined by PSA concentration higher than 0.1 nanograms in milliliter 4 to 8 weeks after radical prostatectomy. This persistent PSA is associated with worse oncological outcomes. However, there remains a question: can persistent PSA predict oncological outcomes in men with low-risk prostate cancer? The aim of this study was to investigate the significance of persistent PSA on prostate cancer characteristics, biochemical relapse-free survival, cancer-specific survival, and overall survival in low-risk prostate cancer group. Low-risk prostate cancer was defined as prostate cancer with preoperative PSA value of less than or equal to 10 nanograms in milliliter, pathologic T-stage 1 or 2, and pathological Gleason score less than or equal to 6. Persistent PSA was defined as PSA value more or equal to 0.1 nanograms in milliliter at the first measurement within 4 to 12 weeks after radical prostatectomy. Our study cohort consisted of 338 men with low-risk prostate cancer who underwent radical prostatectomy at Lithuanian University of Health Sciences Kaunas clinics in the 2001 and 2019 period and had complete PSA and follow-up data. Patients who had no PSA data at 4 to 12 weeks after radical prostatectomy and patients who received neoadjuvant or adjuvant therapy were excluded from the study. Patients were divided into two groups, with persistent PSA and without persistent PSA. Comparison of patients' age, surgical margin, salvage treatment, time until salvage treatment, and biochemical relapse between study groups was performed using T and chi-squared tests. Biochemical relapse-free survival, cancer-specific survival, and overall survival were compared using Kaplan-Meier analysis and log-rank test. The difference was considered significant at p-value of less than 0.05. The study was conducted with permission from University's Center of Bioethics. Here are our results. There were 10.4% of patients with PSA persistence in this group. The mean follow-up of these patients was 194.9 months. When the cancer characteristics was compared, no difference was found between the groups comparing age and positive surgical margin. The group with persistent PSA more frequently required salvage treatment, and the mean time until salvage treatment was shorter in this group. In the persistent PSA group, 31.4% of patients experienced a biochemical relapse in the persistent PSA group, while only 6.3% of patients relapsed in the group without persistent PSA. There was no significant difference between the two groups when comparing death and cancer-related death. 10-year biochemical relapse-free survival was lower in the persistent PSA group. 64.3% of patients in the persistent PSA group and 89.7% of patients in the group without persistent PSA lived 10 years without a biochemical relapse. 10-year overall survival did not differ significantly between the two groups. You can see how the curve looks here. And 10-year cancer-specific survival was also the same between the two groups. We can conclude that persistent PSA in low-risk prostate cancer was associated with a higher biochemical progression rate, lower 10-year biochemical relapse-free survival, more frequent and earlier salvage treatment. However, persistent PSA could not be used as a predictor of cancer-specific survival and overall survival in low-risk prostate cancer group. Further evaluation of PSA persistence in the low-risk prostate cancer group is necessary. Thank you for your attention. Maybe you have some questions.
Thank you, Gustas, for your presentation, and I would like to ask jury if they have any questions or comments.
Gustai, congratulations. Nice, elegant retrospective analysis of our results. What about your personal contribution in that work?
Well, I have done the calculations, and well, actually the idea of this study to analyze the relevance of PSA persistency was made by Žilvinas Venclovas, and I did all the writing of the abstract and well, the calculations in this group. And of course, Professor Milonas supervised me through this. So these are my contributions.
Thank you. Thank you. It's a nice analysis and as well quite right and objective conclusions. So congratulations.
Thank you very much.
Do we have any more questions? If not, then I would like to ask Gustas to turn off his camera. I would like to thank all of the presenters for delightful presentations. Let's take a 10-minute break while the scores are counted. Right after the break, we will announce the winner of this session. So please do not leave this platform, and see you in 10 minutes. I would like to thank the jury for their work today. Thus, after counting all of the jury points, I am delighted to announce that the winner of the session is Matas Pažusis, Rūta Maželytė, Linas Vanslauskas, and Mindaugas Kidelis with presentation about minimally invasive versus open primary linea alba and midline incisional hernia treatment, early follow-up results. Congratulations, and we will contact you later. So the surgery session had finished. I would like to thank all the participants for attending the 5th International Health Science Conference. Hopefully it was useful, and now I invite you to join the rest of the conference and the keynote speakers. Today we have Dr. Skirmantas Krikščionis. He will talk about gene mutation and cancer. So thank you for your interest in science and have a good day.